End-of-life care planning is very important for patient, family and healthcare provider because it helps to determine future healthcare treatment for according to patient's wish, preference and healthcare beliefs. This video also included end-of-life care planning for Mr. A. Mr. A is 75-year-old white male with a history of hypertension, chronic obstructive pulmonary disease and gastroesophageal reflux disease. His GERD and hypertension is well managed with the medication, but his COPD is getting advanced and does not responding to treatment, especially after his last hospitalization with the pneumonia, when he was on ventilator and intubation tube for 8 days. His dyspnea is getting worse and fatigue is getting further progress. His appetite is reduced. He is not able to walk even a few blocks. He is not able to perform his daily activities and need assistance. His palliative performance scale score is 40% and his Karnofsky scale score is 50. He lives with his wife and they both come together in a provider's office for chronic healthcare management. He always have a positive attitude towards life and ever smiling face makes him very special. He has son who lives in another state. He stay in contact with telecommunication but does not involve in their care. After knowing about his healthcare condition and healthcare beliefs, I just recognized that they don't have advanced care directives. So I explained and asked about healthcare proxy. And Mr. A responded that he does not know what that term is for. After assessing for Mr. A's health condition and healthcare beliefs during the communication, I asked him whether he knows about advanced directives because I am not able to find any legal document or advanced directives in his chart. He was surprised with this term and asked for explaining further. So I explained that healthcare proxy is a legal document in which you appoint a trusted person who can make decision on behalf of you when you are not able to make your decision for the future treatment. He said, I wanted to communicate with the healthcare provider for my advanced directives and to deciding for my future healthcare treatment, especially after my last hospitalization when I was on ventilator and had intubation. Tubes in my mouth was very uncomfortable and I want to make it that not happening again. So he was very glad knowing about healthcare proxy and responded that my wife will be my trusted person and there is no one other than her because we spent 39 years together and she knows very well about me, my wish, my hopes and my preferences. Although he knows about this condition, we are not able to complete the formality or complete the document at this time because he had further questions and wanted to ask about that. So we continue the communication. We take the permission from Mr. A to talk about this healthcare planning in presence of his wife and he was okay with that. His son does not have any barrier for this communication and he supports the communication. According to Patient Self-Determination Act, it is required by the facility and provider to make sure that patients know their rights to make decision for the health care according to their state law. As per the Act, it is also required that provider has to ensure for the advanced directives if present in the healthcare record. If not, provider has to provide information related to advanced care directives according to compliance with the state law. Mr. A has not any cognitive disability. He is alert and oriented and able to make decisions. He shares everything with his wife and he gave permission to share information with his wife. Mr. A had made choice that he does not want intubation or ventilator because it was very uncomfortable and he does not want to revise or do anything that can reverse his death. He wants to make sure that it does not happen again, so that he wanted to write it down, but he does not know where to start and whom to ask. I explained him everything about living will, dual power of attorney, and healthcare proxy. After knowing about these terms and legal documents, he assigned his wife as his healthcare proxy to make decision for himself. I again asked Mr. A, how much intervention do you want? And how many intervention do you want? In circumstances when he is critically ill and not able to speak for himself, how much intervention still he want to resuscitate? He initially decided for everything which can make him comfortable, even for the CPR. So I gave him another form to read that is called medical operated life sustaining intervention. I gave him to read it and explain that you can discuss with your wife. You can take it and return it after determining what intervention do you want. He took it, and after some days, patient and his wife came with a determination of how many intervention he want. Initially, he decided to have chest compression CPR because he thinks that it can help him for breathing, because CPR always, as shown in the movie, it is helpful when patient is not able to breathe and he does not want to suffocate. He wants everything which make him comfortable and help him to breathe. I took the form and I just communicate with him step by step. Mr. A has given form and he gave his preference for resuscitation for CPR. So I explained him that CPR is not just chest compression, because you have COPD and it always end up in respiratory failure and you need support from the machines like ventilator or intubation. Further, depend on your aging and healthcare condition, it may not get successful. If it's successful, it may impair your quality of life. Mr. A, after understanding about this condition, replied that he does not want anything invasive. He does not want anything that goes inside his throat. Further, he said if it's just chest compression and it's going to help him, he wants that, but otherwise he does not want if it end up in a breathing machine or intubation. He replied that he does not want anything invasive or anything go inside his body or throat. He does not want to poke himself again from either intravenous parenteral medication or intravenous fluid for hydration. He denied for dialysis, blood transfusion, and feeding tubes. He further denied for surgery, and he said he does not want to go for any advanced diagnostic because it does not change anything. He confirmed that he wants everything that make him comfortable, that make him breathe. That includes inhaler, through mask, oxygen, oral medication, antibiotics, oral medication for pain, sleep, or anything for the infection. He denied for hospitalization or ER visit. He said, at the end of my life, I want to stay at home with my wife and I want to spend that time with a little comfort. So I want everything that make me helpful to get peace of my mind. He asked for spiritual referrals because he has a spiritual need. He and his wife both were aware for the palliative care and asked for the referral for the palliative care. Mr. A has decided that he wants everything at home. He needs every medical treatment at home so that way he can reduce caregiver stress for his wife. After knowing about patient's preference for future treatment, the shared goal set up, and patient's goal was to manage dyspnea and oxygen therapy and nutrition support, to provide comfort care to the patient, to provide social, psychological, physical well-being and respite care for Mr. A and his wife. The intervention that was decided for Mr. A included inhalers that help him breathe, azithromycin, oral antibiotic for his infection, prednisone and steroids, medication for his hypertension, medication for his GERD, and management of dyspnea, oxygen therapy and nutritional support, along with referral care for palliative and spiritual care. With this explanation for end-of-life care planning, Mr. A and his wife both were very pleased and thankful because they wanted to decide for their end-of-life care planning, but they didn't get a time to talk. And with the slight opportunity, a provider helped them to make the decision for their future care. Thank you.